So now let's get started with the panel. We're going to start off with health because, of course, health is the basis of people's well-being. So now, Patrick, you can still have your seat there. Patrick, we have heard you speak of the importance of proactive, oops. Yeah, that was a very quiet cough, John. Somebody else cough when I'm supposed to change screens. Patrick, we've heard you speak of the importance of proactive approach to wellness and overall well-being versus being reactive. We know Griffin Hospital has been a leader in this forward thinking of healthcare providers' focused efforts on prevention and well-being. 60% of the Valley residents self-report being in good health. But when we look at the socioeconomic portion of the data, those numbers drop dramatically. For example, if we look at cigarette smoking in the Valley, 17% on the average say they're smokers. But when we look at those with incomes below that $30,000, the number jumps to 33%. What role does someone's socioeconomic position play in their overall health?
Well, thank you. First of all, thanks for inviting me, and thank you for your leadership in putting together this very important report. Sharon mentioned that this forms the basis of our community health needs assessment. The second part of that we're required to develop, and all not-for-profit hospitals, is an action plan to address the opportunities for improvement that are identified in this report. And I think that's the most important point. It's one, getting this perspective, but intervening. And I think there's a lot of opportunity here to do that. So we're looking forward to that. So yes, what is striking is that there are significant disparities that are pointed out in this report, and I'll probably focus on one or two of them. I think it's important to kind of look at a bigger picture to start. We spend a lot of money on healthcare in this country, so it's not a question of lack of resources, it's just how we're deploying those resources. So if you look at the US compared to other industrialized countries, we're spending about 19% of gross domestic product on healthcare. The average of the other industrialized countries is about 11%. The problem with that is we're not getting the return on investment that we should be. So despite the fact that we're spending much more, so we're, of course, per capita spending on healthcare, even though it's almost twice the average of other industrialized countries, we have the highest percentage of GDP spent on health. Outcomes are not good. We're 25th in the world in terms of infant mortality, 26th in terms of life expectancy. So you have to ask, is it about spending on health that produces outcomes? Well, the reality is, if you look at health outcomes or health status, there are really three factors, and I think you get at it in this report. What determines your health? 20% of it is genetics, essentially who your parents are. So if you didn't choose your parents right, you're at a disadvantage. Right? 60% of it is social, behavioral, and environmental factors. 60%. And only 20% is the actual healthcare delivery. Yeah. When you look at other countries and how they're producing better outcomes, it's clearly not what they're spending on that 20% healthcare. It's really what they're spending on social support and social services. And I think that's really important perspective for this community, where the social services providers work really closely together, and I don't think they appreciate the kind of impact that they can have on health outcomes. And we, as healthcare providers, probably haven't given them enough credit and work as closely as we should, because if we really hope to impact some of these numbers, we need to do that. So if you look at those other countries, the other industrialized countries are spending a whole lot more on health. They're spending 2 to 1 on social services to healthcare. So they're spending twice as much on social services as healthcare. In the United States, it's the opposite. We're spending twice as much on healthcare as we are on social services, but we're producing worse outcomes. So if we're going to look at some of the health disparities in the community, yeah, we can spend more on health care, but that's waiting for people to get sick and then try and treat the symptom. We need to get at the underlying problem. So it's really, if we're going to look at the resources that are available, we're probably going to have to redistribute a little bit. And as a person or an organization that's the beneficiary of all that excess spending on healthcare, I'm not sure I want to say that in public, take money away from healthcare and give it to social services. I'm sure the other members of the panel say that, I like the sound of that. but let's look at one particular focus area in the report, but I think it's one of the most striking. If you look at asthma, and you'll see this as you get into the data in the report, there's a pretty dramatic disparity in terms of the prevalence of asthma and the impacts of that on health. So if you look at, and let me find it here in the report, if you look at ED visits for an asthma diagnosis.
Okay, an ED visit is?
So somebody, yeah, excuse me, thank you for clarifying that.
I'll help with that part.
So these are emergency department visits for an asthma diagnosis. So this is somebody with asthma that has a sort of an acute exacerbation. They have a crisis. So they show up in the emergency department. So if you look at it by ethnicity, if you look at for the white population, it's about 3 visits per 10,000. If you look at the African American population, it's 17 visits per 10,000, population, and the Latino population is about 13. So, okay, that's statewide here in Connecticut. So let's try and translate that into our own communities. If we're going to say, what is it that we can do about this? And by the way, there are children and adults in Connecticut that are dying from asthma. Every one of those deaths is avoidable. If you look at the disparity that I just described between the white and African American population, 17 to 3, we had a young man in Ansonia this summer who was in his 30s with 3 children that died from an acute exacerbation of asthma. That was avoidable, right? So what is leading to this? Access to care and medication to manage that asthma, possibility, right? It's the environment. So you have to look at the quality of housing. Is there something going on in the environment in somebody's home that's leading to these acute exacerbations, right? Is it general well-being, which is things like nutrition and physical activity? So if we're going to solve this, it's not only screening to find who these individuals are and making sure they take their medication, it's a much broader approach that we're all going to have to take to address that problem. So let's look at it by community. And I just wanted to point out, and it's so dramatic, and I'll give it to you right here. If you give me 1 second. Can I put down the microphone?
You can.
All right.
In fact, if you guys want to use the table stand to put the mic in, that's good too.
What's that?
I'm going to tell you, Patrick, you got
Yes,
about a
I
minute.
know, I'm running out of time. I'll sign up. Okay, so just in terms of that ED visits for asthma. So at the high, it's 12 visits per 1,000 in Ansonia. It's 11.6 in Derby. It's 7 in Seymour. It's 5 in Naugatuck. It's 3.8 in Shelton, and it's 3.3 in Oxford. So from high to low, it's a factor of 4 to 1. So 3.3 visits in Oxford and 12 in Ansonia. That's in our own community. So if we want to look at disparities, look at one problem, one health problem, that wide disparity, and we know that there are a series of underlying issues that contribute to that. And we're going to have to address that in the broadest way possible. Right. Again, not just medical care delivery. Obviously, we're not going to do a whole lot about genetics, but that area in between, right, social determinants of health, that's where we need to focus. When we put together our action plan, it's not only going to be the availability of medical care and access, and cost is a problem, and we need to talk about that, and we'll probably talk about that on the panel. But once you get over that, those access barriers, we have to look at how we're going to address this in that broad context.
Great.
So.
Thank you.